Now, there are many kinds of personal health records floating out there today. So I'm now bridging to the third part of my triad. We talked about connectivity and interoperability, and I gave you a schematic of how that may work between networks. Now I'm talking about how does a person get access to that information for their own uses. There are many kinds of personal health records floating around, and I won't belabor these. I'll give you a quick sampling. The most common, frankly, is an institutional portal. Typically a hospital network or a hospital or a major multi-specialty group practice. Think about Kaiser Permanente, Cleveland Clinic, the Partners System in Boston. Those kinds of organizations are providing their patients with a view of the electronic health record that they contain, that they manage for that patient. It's a view. It's not control. It's not really access. It's not retrieval. It's just looking at my data that happens to be inside the walls of Cleveland Clinic, let's say. And that's fairly common now. Those are getting usually 15 to 20% of the patients who are served by those institutions are using those kinds of services. Individual providers. Dr. Jones is sometimes offering the same kind of thing. I think Ed Foch was on the program. I don't know if he's going to be here. Ed offers a service for individual providers to take advantage of electronic medical records management. The untethered class of personal health records essentially means keeping track of your health records in a device or a software program yourself. It's not tethered. It's not connected to a hospital, doctor, pharmacy, lab. It's just in your pocket or on your computer. And you then have to find a way to get the data in there. No one's doing it automatically for you. The fourth, and this is probably the biggest growth category and one for you all to give some thought to, is populating a personal health record, that is filling in the blanks in the personal health record from health plan claims data. The major American health plans, who are members either of the America's Health Insurance Plans Association or the Blue Cross Blue Shield Association, have jointly agreed that by the end of next year, 100 million Americans will have a personal health record populated this way. So if they fulfill that idea, basically all the insured Americans will have, privately insured Americans, will have a personal health record, and it will automatically have in it all the data reflecting their experience as shown in claims data, and in pharmacy claims data, and in laboratory. It's uncertain how much laboratory data will be there, but they were trying to populate it not only with laboratory orders, but with laboratory results, which more and more of the plans have access to. So the health plans see the opportunity to build a personal health record. Many of you may have seen Aetna has started radio and TV ads for their version of this same thing. And these personal health records from the health plans will be portable. So if I'm in Aetna this year and in Blue Cross of Massachusetts next year, the two plans will agree to ship my data so I can keep using the same service that I've had. So that's a very big initiative if truly 100 million people have access to it a year from now. And then there are some specialized personal health records that are targeted toward a population of people or people with a certain diagnosis or people receiving a service like pharmacy services. I've summarized that sort of basically who tends to take advantage of these things. 15 to 20% is the target number. Usually people who need it. It's a good number because these are people who are sick, have frequent use of the healthcare system, and are often trying to manage the complexities of those relationships. This just illustrates, this is from the Cerner company, which is a company that makes laboratory and other equipment. And they've created a personal health record for diabetes patients. And they've been fairly aggressive about trying to get this out there. And you can see it's really optimized just for people with diabetes and for the kinds of data those people are concerned about. This is one just for people tracking digital mammogram images. And if people want to keep track of these images over time, they can, this might actually have a, oh yeah. They can build essentially an online library of their mammogram images and then refer to them and compare them over time. So those are quite specialized. Now, the networking of a personal health record is the next topic I want to get into. What's happening so far in this market, if you want to call it that, is most personal health records are connected to somebody who wants to offer it to you. So if you are an Aetna member, Aetna wants to give you a personal health record. If you are a patient at Cleveland Clinic wants to give you a personal health record. If you're a customer at Walgreens, Walgreens might give you a personal health record. Each of those businesses has a reason to offer you a service, and one of those reasons is loyalty. They are not particularly interested in giving you a personal health record so you can then take it and say, oh, I can get better care somewhere else. I'll take all that data with me. Kaiser is spending a couple $2 billion building their electronic health system, and they are not eager to spend a couple $2 billion building a system which you're going to then take advantage of to go somewhere else. So far what we're seeing is a fairly proprietary approach to personal health records, which is loyalty is one of the reasons to offer it, at least offer it for free to the patient or member who's using it. So we in the personal health record business once had a fantasy that looked like this, which is there's a patient or family in the middle of the picture, and they want to have access to their personal health information in a PHR, and their healthcare system offers it to them, and the doctors and other providers and source services attached to that system populate the personal health record, and the family can happily manage their information. The reality for all of us is more like this. We have many relationships, and each of those relationships is now offering some kind of patient or consumer-oriented electronic service, which means, I use my mother as an example in Boston. She's 86 now, and she has 5 different portals that she can connect to track her information. Medicare has a claims portal. She has 2 health systems in Boston. They each have patient portals. She gets her drugs from Caremark. They have a place she can refill her drugs online, and so on. There's no commonality or connectivity or ability to tie data together from those 5 sources. And this is the very beginnings of this new field. So one concern we have is this is going to proliferate, and all of us will have dozens of PHRs that are essentially disconnected and don't provide much value. So the theory is, could we have a personal health record which captures data from many sources, and then we access that? And all of you who've been frustrated for your careers over the fragmentation of the healthcare system, the fear I think those of us have now is, while many of us have seen IT as a possible solution to fragmentation, as a way to virtually knit together all the pieces of our healthcare, instead it could be just another form of fragmentation, where we have disparate standards, lack of portability, and no reason for people to share data. So the goal is to create a networked personal health record environment that achieves confidence by you and I, that we are willing to trust. And I know an awful lot of people who just say, I'm not putting my health information on the internet. That's a scary place to be when we look at the number of lost data, identity theft, and so on. So how do we overcome that concern? You've already seen this design of how these networks talk to each other. The question is, how does a consumer get on here? Now, in the simple case, if Cleveland Clinic, let's say I live in Cleveland, I go to Cleveland Clinic, and Cleveland Clinic is part of the Cleveland Snow, let's say, then maybe Cleveland Clinic will let me get out my data, and that solves the problem. If I want to get my data from San Diego, where I used to live, I'll just have Cleveland Clinic go through its back door, retrieve my data from San Diego, and show it to me. And that works fine as long as I have that relationship with Cleveland Clinic, and I want that to be the broker of my health information. But I may not want to do that for a lot of reasons. I may not have that relationship. I may not trust or like that to be my intermediary. I may not want to have the provider network, the institutional network, manage my relationships. So we have come to believe that there has to be a class of organizations or entities or services which stand between the consumer and this complicated network and essentially represent me to the network. We're calling that a consumer access service.